away with a lubricant. If they're talking about any like urinary symptoms, then we can use one of our vaginal preparations. If they're talking about vasomotor symptoms, then we can use one of our systemic options that we have. What else was the bigger things than that? Those are the big main things that we talked about with the first part of this. So looking at some of our other, hold on, okay. Our other hormones, these are going to be things that we're using for several different indications, and we're going to go through these and then we'll talk about some of the things that we use for sexual dysfunction. So looking at this, this is going to be for our advanced breast cancer, estrogen based. This is something that we still see used quite a bit. A lot of these drugs for breast cancer mechanism, again, essentially with what it says in the name, so aromatase. So it's blocking the aromatase, which is that enzyme that's going to kind of make, I guess, or help distinguish our estrogen, and it's being made from the androgens, okay? So we want to stop the aromatase. So inhibiting our aromatase, your products that we have, all oral options, letrozole, anastrozole, and your exemestane. Anastrozole is the one that we typically see the most of. Letrozole has been being prescribed a little bit more now as well. Looking at my adverse effects, these kind of look similar to the same things that we were talking about before. So you see that hyperplasia back up again. We have some cardiovascular diseases, so just pain, MI, potentially osteoporosis, or just the depleting, the bone, and then your musculoskeletal pain. A lot of people will say, like, whenever they have started taking it, that they feel like, I think about the Tin Man, like that stiffness that they can feel whenever they're starting to move, and then over time, it gets better as they continue to move. But again, whenever they sit down, they may see that stiffness kind of creep back in on them. Contraindications, of course, if they're allergic to any of the medications, then they shouldn't take them, so no real contraindications that you have to look at here. And then your interactions that you have, if you're adding another estrogen to it, so we've been seeing a lot of this estrogen and your compounding estrogens, right? Like this is the same kind of idea, so you'll see decreased effectiveness in these medications. Same thing if you add tamoxifen, decreasing the effectiveness of any of those three medications. And then your methadone, which we're using for, well, depending on what you're using it for, but methadone, you can see that this can increase or enhance the potency of your methadone, which we don't need that to happen, okay? So just make sure when you see these musculoskeletal pains and the stiffness, the importance of trying to help treat that breast cancer outweighs the stiffness. So what we do is sometimes we can give them an NSAID to kind of help relieve some of the pain that they're feeling from that stiffness. And we also sometimes will see where we can do duloxetine to kind of help with some of that pain also that they may experience. Okay, so those are two options that you kind of have to help with that pain that they feel in some of that stiffness. Here, progesterone antagonists. So we talked about when we're adding progesterone, and we talked about progestins, but we haven't talked about anything that is doing the opposite of that. So essentially, it's trying to inhibit any of those activities that we talked about that the progesterone does, right? So trying to get that body ready for like the baby and all of that. This is doing the exact opposite, and then just again trying to stop any of the activity that we could potentially be having if it does have any glucocorticoid activity. So your medications that we have, mifepristone, you see that there's two different brand names, which then give you two different indications. So when you're looking at your mifeprex, this one is going to try to be the medication that we don't use for this anymore in most states legally, is to terminate pregnancies, right? So you can still see that this medication is something that is around. And then you see your Korlym, and this one is to help with Cushing's disease if somebody has elevated levels of glucose. So again, same exact drug as far as like the chemical structure of it, it's just branded in different ways. So say that they're ordering Corlym and use it for something else, right? So also people still can get this by ordering it online and things like that. So you will see cases still where people may come into you and they're in pain, especially if you're in an ER, and they've taken this and they were pregnant trying to abort their baby themselves. These are things that are still happening, okay? It's not like the drug is not made anymore. All right, looking at our adverse effects. So think about just the way of the drug and what it's trying to do. You're going to see where you can have a lot of nausea, vomiting, diarrhea, like cramping essentially that's happening. You can also see the hypertension. You see several different pains that can happen all over their body. Again, depending on how long they're taking it, like the person who's using it for cushions, they're going to be taking it for a longer period of time. These are things that you're more likely to see. If somebody was taking just one dose of this, they're not going to see as much of this. More so, it would be like the pain and the nausea, vomiting, diarrhea, lots of severe cramping. Again, we see that hyperplasia back, so this is something that's been a common theme throughout. And your contraindications, if somebody has an IUD, they're pregnant, or there's an unexplained reason why they're having any type of vaginal bleeding, we don't want to give this because that means that there may be something wrong in that area where this drug is going to essentially be working, and we don't want to cause any more issues. The hypersensitivity is, of course, the same thing that we've always talked about. They're allergic to it, they don't take it. Your interactions that you have are going to be, just remember your SIPs, and then this is different because we don't see a lot of PGP, right? PGP is not something that is often seen with us having a lot of interactions. So it's a PGP inhibitor, and then we have grapefruit juice, which is something that we saw before with which drug class? Did you see grapefruit juice with? Okay, what else? A big one that y'all just had that deals with lipids. Statins. Okay, that's like a test thing that they like to ask us all the time. Testosterone. So when you look at testosterone, used to have a very bad rap. Now new studies have come out and shown that not as bad as what we thought it was with some of the adverse effects that we're going to talk about. So this is something that is prescribed that you could be potentially prescribing. The patient usually will have an IM route. We do sometimes have the pumps, but it just depends on the patient's situation. Make sure that when you prescribe this, and again, you prescribe the syringes if you're giving them the IM formulation. We give them a vial, they inject themselves, okay? So you need to make sure that the size of the vial that you order is appropriate for the amount that they're administering themselves. So sometimes we'll see where a prescriber will give a 10 ml vial, and they're really only using like maybe 2 or 3 in a month. And it's like, what are they doing with the rest of it, right? So they have a lot of extra testosterone kind of hanging around to do whatever they want to with. So make sure that you're getting the right size vial with what they're actually taking. So again, very good medication whenever we need to use it. What you'll see is that, sorry, I'm trying to get my laser pointer. This is a big thing as to why we like our IM formulation, because it avoids the first pass. The dosage that we get if we try to give this orally is so minimal. We are looking at better ways to make oral formulations, and I'm sure they'll figure it out and some come on the market and they go back off the market. But the main formulation that we have is IM. You see that we do have these others. Topical is the second. All of these other ones kind of like, yeah, we don't use them as much, okay? So looking at when we're using our testosterone, this is going to typically be for our patients who have anemia or who are starting to see like that poor bone formation very early on. So your senile osteoporosis. When you're looking at your males, this is typically why we see it, okay? We have started to see this in a lot of younger patients as well. So please make sure that you are prescribing it appropriately. When you give it to a younger patient, it's a lot of red tape that they have to go through. We have prior authorizations and everything as well. But testosterone deficiency, hypogonadism, if you see that there is a delay in growth of a child, you can also potentially give them the testosterone for that as well. And then impotence, and that's why we've been seeing it a lot in our younger patients, because we have a lot more people who are taking antidepressants, because we have a lot of people who are taking medications for their blood pressure, right, to lower their blood pressure. That also will cause impotence to occur, and so that's why we see a lot of younger patients now being prescribed the testosterone. So see if you can adjust other doses or change to another drug class if that is the main problem that they are complaining about, because you don't want to, right, you're giving a drug to now give another drug, which has a lot of restrictions to it, okay? Looking at our females, because we can also still have females who are prescribed testosterone. Again, your hypopituitarism and then breast cancer. Don't really see this a lot. I've maybe seen a handful of patients who are female who we give the testosterone to, but again, that was in the military setting on the outside in Walgreens. I saw it often, okay? So in options that we have. Drug abuse, of course, that's what we know a lot of testosterone being used for, bodybuilders, things like that, right? Just building that muscle mass. Again, this is not something that you will be prescribing it for. Just look out for it because you will see patients who misuse it. They can order it online, right? You have Hims and all those commercials now where people can get a lot of things online, okay? These are all going to be Schedule 3. So they are controls. So that's why I was saying, if you have somebody that's on an antidepressant, if you have somebody that's on something for their blood pressure, and now you're having to prescribe something like this for them, okay, see if we can change that other drug or give them a different drug class and still work, still get their blood pressure under control, still help them with their depression, but not prescribing a controlled medication to them if we don't have to, okay? So play around with that before you're giving this, if you can. And then your adverse effects. So these are a lot of things that we saw over the years, and then of course you see more of this happening in people who are using it in an illicit manner, okay? So if they're using it to increase that muscle mass, they're usually using higher doses, they're usually using it more frequently than the way that you would typically prescribe it. So when you're looking at this, the microembolism, increased risk of high blood pressure, things like that are the things that are more minor. LDL, so just think about all of your lipids being out of whack. When we're looking at our adult males, what you're seeing here is that now they're having issues with their sperm and the quality of the sperm, right? So then it becomes more difficult for them to have a child, things like that. And again, the longer they're on it, the higher the dose that they're on, the more likely you are to see this occurring in those patients. Also, you can see, again, because of all the lipid abnormalities and things that can occur, so dyslipidemia, you can see where they can start to have gynecomastia, so they start to form that breast tissue, and a lot of patients do say that it's painful, especially if they're a male, whenever they have that happening, okay? So again, higher dose, longer use, more likely to see these things happening. And then the priapism happening, again, they have to come to the hospital. You'll have to drain that for them if that does occur. So it's working, but not work too well. And then you could potentially sometimes see with overuse where one of our indications to use it, bless you, the impotence, you can also see that happening. Before someone hits puberty, you can see where their growth could potentially be shunted. So that's like, I can't remember his name. Did we call him Hercules? Remember the little dot who was lifting weights? Y'all remember him? But everybody thought that they were giving him steroids. I never followed up to see if that was true. But he was very little, but he had like really, really big muscles. And so people were thinking that they were giving the baby testosterone. Well, he wasn't a baby, he was a child. Testosterone, and that's why he was that big. They were saying that he just works out. So think about, like, if you were to give someone testosterone and they're younger, they're gonna be smaller, okay? It decreases their growth. What else did we talk about that did the same thing, that if I gave them a lot of it and they were younger, that it can decrease their dose? It can come in the form of an inhaler. Remember when we were talking about our steroids and how if we give them higher doses of like any of our steroids, inhaled steroids, or if they're taking an oral steroid, that can also do the same thing. So kind of start grouping these things when you can together, because those are like our exam questions that they can also ask you. Let me see, females, just think of a female becoming more masculine, right? So acne, because of the lipids, Facial changes, hair growing in places, voice changes. So like, just think of making her more masculine, okay? Those are all the big side effects that you're gonna see here. Now, this side looks very busy. I'm gonna tell you what you're focusing on and how we're gonna use it. So when you're looking at your long-acting, this is gonna be your IM injection that we're typically using. We also have the implant. I don't need you to remember the different uses here, because I just want you to remember your uses on this slide, okay? You know these, that's fine. Don't worry about it in the chart, because it kind of gets a little bit different per drug, and I don't need you to remember it that way. So here are all of your different ones that you have. You see that they all say testosterone in them, okay? I want you to make sure that you're looking at your comments over here to just understand what your adverse effects are that you're trying to make sure that you're looking out for, and then also making sure that you're understanding how you're going to counsel your patient, right? So that's all I need you to look at over here. This one, your pellets, don't worry about all of the breakdown of this. Just understand that it's an implant that they're gonna have, and it's gonna slowly release that testosterone for them over time, versus their IM therapy, depending on how you dose them and what their testosterone deficiency is, the indication that they're using it for, they're not giving themselves an injection every single day. This is usually something that they're gonna do either weekly or bi-weekly. Sometimes they'll just do it once a month. So that's why I told you to make sure that you're paying attention to the vial size that you're giving them, and make sure that you select the correct day supply. That's the biggest thing that we see in the pharmacy, is that we'll give them that big vial and it'll say that they're using it for one day. And it's like, they're not using 10 mLs in one day. We know they're not. Okay, so make sure that that matches. So understand, these are your IM formulations, your transdermal. What that is essentially they're going to either have a gel or some type of solution that they're going to use. Usually we have them dispensed out of a pump. And so what they will do is they will pump, or they will have the tube. Most people like the pump because it's just a little bit cleaner. And they put it on their body. Again, same thing that I told you guys with like estrogens, if they were using them topically, make sure that they're covering up the area that they're putting it on. Okay, so your transdermal options that you have, there's several different ones with several different strengths available. Then you have your oral options. Again, these are the ones that are going to come on and off of the market because of that bioavailability. So as we start to get more information about the efficacy of it, that's when you see these kind of start to fade. So right now, these are the only two oral options that we have. And then your intranasal, this one I haven't seen prescribed often, but it's the only one that you have, and it also starts with an N for the brand name, the Testo. And so, again, a way for them to inhale if I don't want to inject myself, right? And this is, they don't have to come into you for this. You're prescribing this, they're doing this on an outpatient basis. With the gels, again, just making sure that you're understanding that they're not putting it on their testicles, they're usually putting it somewhere else on their body. Make sure that they cover that area that is on their body. And then if they're putting on deodorant, they can put, if they're using it under their arms, they put their deodorant first, and then they wait, and then they put the medication. And then your oral options, again, just check your TRICARE formulary lookup tool before you prescribe an oral option if someone does want it, to make sure that we still cover it, and to make sure that it's still in Genesis whenever you go in there to order it. And then looking at this, just understand that you see that we can potentially get weight gain. So if this isn't something that somebody is looking for, then of course don't prescribe this option. Also making sure that you understand with this oral option that we are watching out for a lot more side effects, because this is more systemic as well, okay? And now it has to go through that first pass. So this is one of the ones where we see a lot more of those side effects, which is why we don't see it used as much either. Danazol. So when we look at this, this is essentially trying to say that I want to suppress my pituitary from releasing my FSH, my LH, which are the things that we talked about before that ultimately are going to affect the amount of testosterone that somebody has. So if you just look at the bold part of this, that's enough for you to understand your mechanism of action. When you're looking at your clinical use, you see that we have our endometriosis, and then we talked about this this already with our GnRH analogs and how most of the time we're using these over using our danazol. So the most of the time we're using danazol for our endometriosis. And then this one good thing about this is that now I do have, and this one is only available in my oral option, doesn't have that extensive first pass like we talked about with our testosterone, okay? Anti-androgens and androgen antagonists. So when we talk about an anti-androgen, again, these are good medications that we have available. There are several different indications. So when you're looking at this, kind of look at all of our indications that we have. And when we talk about anti-androgens, remember we said with our progestin sensitivities and our androgenic sensitivity, like they're more likely to have the acne, the hirsutism, all those things happening. So this is trying to say now if I have an anti of that, I can decrease these things. So these are a lot of your indications that you see, right? So if I had too much, right, I can help with that. If I had acne, these are the two things that we've already seen when we saw anti-androgen. Your prostate cancer, endometriosis again. So if you remember cancer, I won't put a random cancer. Cancer is good enough to know that we can use it for that. Endometriosis, and then your precocious puberty in our males. We have that. This is a second drug now that you're seeing that we can use that potentially for. And then the big thing that you will likely be prescribing this for is going to be BPH. You see that we're having several different types. I will just tell you BPH, but this is just for you to look at so that you can understand what the symptoms are completely. I'm not asking you to diagnose, I'm going to tell you. So if you remember BPH, that's fine. All of this is just extra information. So what we have our alpha blockers, and we have a 5A reductase inhibitor. So with your alpha blockers, what they're doing is, these are again trying to say, hey, I'm stopping, right, what's going on. I'm trying to decrease and help, I'm trying to decrease the hesitancy and the inability for this person to go to the bathroom. Because again, I want to focus on BPH because that's typically how you're using it. So blocking your alpha 1A mediated contraction of the bladder neck, proven to decrease those symptoms of, so like when someone has BPH, they feel like they have to go to the bathroom and then they go, but they don't have complete emptying. So their body is kind of like still holding on to the urine. So then they keep feeling like they have to go, but when they go, they're straining to try to go. And then that kind of perpetuates the BPH. It makes it even worse over time. Okay, so this is going to help decrease those symptoms to where they're allowed to have the relaxation of the bladder. And then that way they can fully void and not have that urgency that they are continuing to have to go to the restroom. So you have terazosin and doxazosin. These are typically used for BPH, but you also have the indication of your hypertension. You have your alphazosin, which is only for BPH, and then your tamsulosin. This one is more selective, less side effects, and you see that it is BPH as well. So again, remembering BPH over here, don't worry about all of these. I told you I want you to remember BPH. Don't need to look at obstructive versus irritative. And then over here, just know which ones you have for these indications, because these are your more popular indications that I want you to focus on, okay? So which ones are just for BPH, which ones are for BPH and hypertension. So this is your focus for your use. Make sure you're looking at your mechanism for these. And then your 5-alpha reductase, which is your finasteride. We'll talk about the mechanism of action on the next slide. But with this one, what you're doing is you are trying to stop the 5-alpha reductase. Your 5-alpha reductase is what is going to be breaking down your testosterone into your DHT. And so we're trying to say, hey, if I can stop that, then I can stop the growth of the prostate, which is what is going to be the problem, and that's what causes a lot of the BPH symptoms. Okay, so that is your mechanism of action. Stops the BPH progression, reduces the size and symptoms that that person is going to have for their prostate. Okay, so it's in the name, 5-alpha reductase. You have one that you're looking at, which is your finasteride. Now, same thing that we talked about before. You have one drug made the same exact way, different brand name that has different indications. One will be approved in TRICARE, and one usually is not approved through TRICARE. So when you're looking at your Propecia is the one that you have for your male pattern baldness. So your alopecia. This one is very like tricky on if they will pay for it or not because they feel like that is cosmetic, right? Your hair is cosmetic. But you have finasteride, which we use for BPH, which is the same exact drug. So the indication, because of the brand name, is different. So just the dosing is a little bit different in the two. If you're trying to get it approved, more likely than not, your Propecia will not be, but your Proscar is. I have seen it approved before, but it's like very rare. All right. Again, your treatments that you have, BPH, we can see this used in conjunction with one of our alpha blockers, but very rarely do we have to use both of them together. It is a possibility. So they are grouped together, but they're not contraindicated. So that's why I have them on this side. These can be used together. So you can put a terazosin with your finasteride. Okay, so most of the time when you see stuff like this on our slides, it means that you can't use them together because it's additive effects. This one we can. Okay, you can use them together. And then off-label use that you'll have, you'll see some women being prescribed it for their hair loss. Again, that would be something where TRICARE is not going to pay for that. It would be out of pocket unless there's some you can prove medical necessity. Then again, a very rare situation. Adverse effects, some things that we might not want to see, right? So we're saying that we're decreasing a lot of that testosterone, all those things in these patients. We're decreased libido, ED. You can have where their ejaculation could be affected. So it could be where they may not have the same amount that they used to have, or that they don't see it happen at all. Those are possibilities that occur whenever they're taking these medications. This is one of those meds that is highly teratogenic, and so much so that if someone is pregnant, they shouldn't even touch the pills. So in the pharmacy, if we have a pregnant person, we don't let them open the bottle so that they can smell any of that. So make sure that you're understanding that if someone has a partner and they are pregnant and they're taking this medication, that they should not be in contact with this medication, okay? So contact with it at all, semen, any of that, they should not be exposed at the time that they're pregnant. Okay, sexual dysfunction. So we have several different medications that we can use. And again, these have lots of restrictions on them. Usually they only get a couple of pills a month, and I think they usually get 18 for 3 months, okay? And so that means that they need to divvy it up, okay? They need to be wise with how they're using them. But again, you'll have now some patients where they will go online because we have HIMS and all these websites now, and they will buy them out of pocket. So that is not through insurance. They can get some through TRICARE, but not all of them will be covered through TRICARE if they are saying that they need one like every day, okay? All right, this is just going through essentially the mechanism or how someone gets an erection, and essentially what happens, the male will have an increase of blood flow that occurs because you have nitric oxide making the cGMP, okay? So this is just a definition slide for you. This is not something that I'm going to ask you about because I tell you what your patients have, okay? So this is just telling you because this is how some of our medications work. There are several different things that can cause erectile dysfunction. We talked about several meds that can cause erectile dysfunction, right? So if I just told you that I have to increase blood flow, I have to increase the pressure to that area. If I have a medication that's doing the opposite of that, then that's something that can also contribute. So we have different medications that can cause that to happen. We have antihistamines, we have our diuretics that could potentially cause that. Think about anything that lowers their blood pressure. Antidepressants we have. And then sometimes another thing that we don't think about that's on here, it's down here at the bottom, is our alcohol. When people drink alcohol, they also have erectile dysfunction sometimes as well. So make sure that you're asking your patients what's going on before you just prescribe them these meds. Because if they're having issues performing and it's Friday and Saturday, and that's when they're drinking a whole bunch, is on Friday and Saturday, they don't have erectile dysfunction, they're drinking, and it's the alcohol that's causing the problem, so therefore you don't need to prescribe a medication, okay? So get the root cause before you start prescribing medications, get the full story. And then do your med rec, So please, on this, just pay attention to the drug class. If I ask you a question about this, I will have it as a drug class so that you know which one that you're picking. Atherosclerosis, again, if I can't get adequate blood flow there because my anatomy is wrong, right? If I've hardened those arteries and now things aren't flowing the right way, that can also cause issues for me. And then we already talked about a lot of these, and diabetes is just messing up everything all the time. Okay? So what we have is our PDE5 inhibitors, or our phosphodiesterase 5 inhibitors. And what they're doing is they're inhibiting PDE5 so that your cyclic, your CGMP, can stay around for a longer period of time. And we said that that CGMP increases our nitric oxide, and therefore I have an erection. So this is a good thing for us. We like our PDE5 to stay around, okay? We like, yes, we like for our PDE5 to be inhibited, okay? Now, what has to happen? Just because somebody takes the medication doesn't mean that they're just gonna all of a sudden have an erection and they're walking around with an erection. They still have to have stimulation occur, okay? So it's not like you take a pill and then their penis is just like erect the entire time. They need to have an encounter. If there is no encounter, then they wasted that pill. And remember, there's restrictions on how many pills they can get, okay? So this needs to be like something that they know is going to happen, because if not, then they can ask you for a prescription and you can still prescribe it, but you're gonna have to have a paper prescription to write for them to go on the outside. Because again, TRICARE will not cover it. And at our pharmacies, we don't have cash registers, we don't take money. So even if TRICARE blocked it, right, if they had a prescription, they could go to Walgreens and they could buy it. But if there's no prescription, they can't get it. But with us, if you only have a prescription with us, we just tell them no and we refuse and they don't get anything, okay, because we don't deal with money. So you can still help them, you'll just have to write a prescription for them. So clinical use, you see that you have it for erectile dysfunction. We also can use it for PAH and BPH. We see these two indications used not as much. The dose is a little different than what you're using it for erectile dysfunction. So that kind of varies in the difference of these medications. So again, could you potentially be using this for two things? Yes, but the doses are not exactly the same. Need you to remember the duration of them. So you have avanafil, sildenafil, and vardenafil. These last for 4 hours, and your tadalafil lasts for 36 hours. And I remember like 36 hours is a long time. Okay, that's a long time, all right? So this is why you'll see most of the time we like to give them their tadalafil or their Cialis, and that's why a lot of people like the Cialis because it lasts a little bit longer than the other ones, okay? So this plays a role in what that person is doing, what that person is requesting, right? If they're wanting something that lasts for a longer period of time, tadalafil. Adverse effects that you have, because we have that increase of the nitric oxide and all of these things kind of hanging out for a longer period of time, flushing, headache, just think about things have now sped up. I've increased that blood flow, right? Because I'm trying to help this person get an erection. So these things kind of make sense. Hypotension, priapism, again, pops up. We do see this happen. Again, that's something that you would have to help them with. The vision changes can occur. And then with this, a lot of times what we'll hear people saying more of is going to be that stomach ache and the diarrhea. You can see nasal congestion happening from it, but most of the time people don't care. If they can have an erection, they're fine. They'll breathe through their mouth, I guess. They don't really complain a lot about this. But we do hear this a lot, in that dizziness that can kind of happen in some of our patients because of the hypotension. So just be very, very aware of that. And then again, make sure that you're looking at these vision changes because that's something that's kind of abnormal and that we don't see a lot in a lot of our medications. So here are, again, our drugs that we have that are PDE5 inhibitors, okay? When you look at your sildenafil, you see that, again, same generic drug, sildenafil, 2 brand names, 2 different indications. When you look at your Revascio, and this is how we found out about sildenafil or Viagra, and that it helps with erectile dysfunction, we were trying to treat PAH, and they saw that people were, like, with stimulation, they were having erections, and so they're like, oh, maybe it's this drug. And And so then they came out with Viagra. They branded it and they charge lots of money now for Viagra versus you getting Ravaggio. Again, same exact medication. Raynaud syndrome, that's just an off-label thing. If you see this, it's a pretty interesting thing to see in some of your patients. Don't worry about the doses. And then again, make sure that you're looking at this creatinine clearance less than 30. We have to renally adjust. And then the same thing with that hepatic impairment. So if somebody has any type of liver or renal issues, we are concerned that doses need to be lower, on the lower end. Vardenafil, again, this is a good one because you see that I have several different tablets, different doses, and then I also have an ODT if for whatever reason someone doesn't want to swallow the pill, or if they want it to work a little bit faster, we have an ODT formulation. And then looking at your dose, again, don't worry about how long, but this is something that's kind of important for patients to understand. They're usually taking it before they have a sexual encounter, okay? So it's not like they can take it and then like right away it's gonna start working. But that's why I was telling you, it kind of has to be planned on what they're doing, or they need to be ready to take their medication or have their medication with them. Some are less than others, and I'll focus on the quicker ones. Those are the ones that I want you to know. And then looking at your vardenafil, again, making sure that you're worrying about liver impairment. If somebody has any type of dialysis, we wouldn't be using this. Avanafil is the first letter of the alphabet, and so I say that it's the quickest one. Avanafil works almost ASAP, right? So 15 minutes-ish, 15 to 45 minutes, so average of 30 minutes, 15 to 30 minutes, you'll see that this is starting to work, right? So this is your quickest one that you have that will work, okay? So remember your 15 to 30 minutes. And then again, just like with your sildenafil, you have that creatinine clearance and your hepatic impairment that we're worried about. And then your tadalafil, this one was the one that we said lasted for how many hours? 36 hours. And so we have two different brand names, same exact drug, but now I have another one that I can use for PAH. And then you see that my Cialis I can use for my erectile dysfunction. I can also use it for BPH. And sometimes we will see this used quite a bit for the BPH. This is the one that we see used more often for BPH. I'm like, what are you and your doctor talking about? Because they get more pills instead of the dose that we give them for the ED. Again, this one is pretty quick as well. You have that 30 minutes prior to. All this other stuff, don't worry about this. This is for your people who are like usually paying for them and they take them every single day. If they're taking it every day, it's already in their system, right? And so you don't have to worry about it. And this dose is lower. We don't give them that higher dose if it's something that they're taking most of the time every single day for ED. We do give doses that could be potentially higher for our BPH that they're taking every day. So that's what you see with the 5, okay? They'll still have the benefits that they're getting for ED, even if it's just for BPH. And then looking at how often someone is having to take it. So because it does have that long half-life, if you see that somebody is taking it more than twice in a week, or they're coming back and they're like, hey, this isn't lasting as long as it should be lasting, then that's your hint that they could be potentially one of those patients who would need to take it on a daily basis. But again, that's not something that would be fully covered by TRICARE. So just let them know that they might have to pay for that out of pocket. And then your renal impairment, again, making sure that you're worried about it or adjusting for it. So that's package insert. When you see these renal impairments, it'll tell you the maximum dose that they can take according to whatever their creatinine clearance is or whatever their Child-Pugh score will be. Okay, so that's you opening up Lexi drug or whatever and figuring out what they need. Because a lot of our older patients do take it. People who have poor creatinine clearance, they do take these meds. Okay, so highlight for this, remember what your drugs are, remember what your comments are, remember your Avanafil is the one that almost works ASAP, and then remember which ones you have that can also help with PAH and BPH, which are the things that I bolded. Remember with your Vardenafil that you have an ODT option that's available as well. And I won't try to like trick you with the brand or like the brand name being different for two things. Just if you see tadalafil, know that I have indication. I have 3 different indications. I have PAH, BPH, and I have erectile dysfunction. Don't need you to remember like, oh, it's Absirca that is the one that's only for PAH, okay? Just remember what your generic is. Okay, when we look at these are a lot of the things that are going to interact with our PDE5 inhibitors. These are the questions, and these are why you have to ask questions when patients come into the ER and if they've taken Viagra, if they're having any type of heart issue or something where we're having to give them a nitrate, we need to ask them because we can tank them. So what I need you to remember are that all of these things over here interact with your PDE5 inhibitors, okay? The only other thing that I need you to remember here is that PDE5 inhibitors are going to be contraindicated with your nitrates because again, we're going to lower our patient's blood pressure too much if we give both of those things at the same time. And so we ask patients this, especially if they're conscious, because we don't want that to happen because now we're going to be managing 2 different things. We're trying to deal with the nitrates that we're giving them for that cardiac issue, and now we're dealing with their blood pressure also, okay? A lot of times patients are not going to answer you when you ask them this question. So if you're like a patient that is within our facility or they go to any type of MTF, we can look that up. So just do a quick med rec to see if we see it in there, okay? Because a lot of times they'll be like, no, I don't take anything, I promise. And I'll look at them like, we can kill you. Did you take? Oh yes, I did. So you have to like actually get it out of people because they're embarrassed that they're taking a PDE5 inhibitor, they're taking Viagra or what have you, okay? And then your alpha blockers, understand that if you're trying to treat a patient who has BPH, that you want to pick something that is more selective. So your alpha-1, specifically alpha subunit, for your tamsulosin, you have less of a risk of that hypotension if you're giving that medication in addition to one of your PDE5 inhibitors. So again, just understand that these are all interacting, and then only worry about your bolus. I don't need you to look at any of the other mechanisms. That's for you to look at later. I just want you to know that these things interact with these PDE5 inhibitors, and then make sure that you're looking at the bold over here. All right, your alloprostadil. So when we look at alloprostadil, essentially what this is doing is this is causing vasodilation of the smooth muscle, which can then help that patient have an erection. You'll learn more about these in peds, but it's for like for PDA. When you guys talk about PDA, you'll see them using this as well. In this situation, what they're doing is they're going to have a syringe, they're going to inject themselves in their penis for them to have an erection. Of course, this is an alternative to using a tablet, right? Everybody sounds like they would prefer a tablet. I don't have a penis, but I don't think that I would want to inject one if I had it, okay? So, when you're looking at this, right, syringes, the size of the syringe is important, okay? Don't give them a huge needle, right? Like, they don't need that. They want this to be as painful as possible. So, when you look at this, most of the time when I see this is going to be for my patients who have had some type of nerve damage, and that's why they're not being able to get an erection. We had a patient when I was at Bliss, and he was in a wheelchair. I mean, I didn't get all in his business, but he always had to take this one because when he tried the Viagra, those didn't work. None of the PDE5 inhibitors worked. Okay, so a lot of your patients are going to have some type of injury, like some type of neurological issue that's going on, and that's why they ended up using this particular one. When you give them their first dose, just make sure that you're starting it in the clinic so that they understand how to inject, making sure that they don't have a lot of side effects that will happen from it. So just, you want to see that first dose, teach them how to do and use that injection the first time. You see that we have different ones. So your injectable, you have your Caberject and your Edex, and then you have a pellet, which is called the Muse. And so this is the pellet insertion that you see. So it comes with this little, not really a plunger, but a plastic piece that they will take the pellet, they put it in the urethra, and they push it down, okay? So again, this is why this is alternatives. Y'all's faces are that's why this is alternatives to our oral options, okay? So when you're looking at this, make sure, again, your contraindications, anything that would cause a person to potentially have a priapism in the first place, we don't want to use any of these meds because you're increasing the likelihood of that happening, all right? So sickle cell, even if they have the trait, leukemia, things like these underlying conditions, myelomas, all of these things are reasons why we can see that they're increasing a risk. The other thing that you have to worry about is if they have any type of abnormalities in their penis. So when you have people who have like Peyronie's or any of that, or they have what's the word I'm trying to, fibrosis down there, that makes it harder. And now you're going against that person's natural anatomy and trying to shove something, you're causing more issues, you're causing more harm, okay? And at that point, I don't think they would want to have sex after trying to do this anyway. So this is not, the muse in particular is not something that would be an ideal situation for that patient. That formulation is not a good option for them. Yes?
So I guess, is this more like a temporary thing? Like when they go for a penile pump then? Like for
So when you use penile pumps, like I said, I had a person who picked this up for 4 years. They did the injection. But I mean, probably over time you get used to it. But I'm just saying, like just from my daughter gets infusions, right? She gets them every month. She's used to getting she doesn't even cry anymore. So I'm assuming like over time, something, a diabetic patient, they poke their finger all the time. It's not a temporary thing. A pump is an option. Most of the time when you get to a pump, it's because they're not responding to anything or they've had like some type of structural reason as to why they can't take anything else. It is an option and it's a discussion for the patient to have because I could say I don't want to do either of these at all and I could potentially have a pump. So yes, that's an option, but this is something that someone could continue to do all the time if they wanted to. And you could potentially just be prescribing this for them all the time. They still have limits on how much they can get to, just like our oral options, yes. No. So you're looking for adverse effects and you're looking for not if they respond to it. You don't need to stimulate your patient because you don't get in trouble. Okay? Or tell them to no. So you're looking for the adverse effects that could potentially happen to your patient, okay? Don't do that. We like our license, we like our job, okay? Do not touch your patient like that. I have never had that question. That is a great question. No, they will tell you if it works. Okay? They will come back for their follow-up and tell you if it works. You don't figure out if it works, okay? All right. All right. Y'all are great. Okay, so for our additional meds that we have that are your patient can get over the counter, some of these, right? This is a non-FDA approved herbal supplement that you will hear some people tell you that they're trying. Again, you don't have to knock someone trying something. If it works for them, then great. If not, that's why they're usually coming into you in the first place. But just let them again know it's not FDA approved. We don't know what's in it. If it works for them, great. If not, they're usually going to be coming to see you anyway. And then we have our androgens. These are just other options that we have that are available. And then we already talked about our alprostadil, which was our Muse, our Catavect injection or the pellet that we have for them. We also can potentially have female sexual dysfunction that can occur. So when we're looking at female sexual dysfunction, we can't use our androgens like we just talked about for our males. They're not approved, but we have one thing that is approved, and that's our flibanserin or our Addy. And this is the only thing that we have that is approved for our women, okay? So all of these other things that are here, so we'll go over your hormonal therapy that you have. You see that we have the testosterone, but again, it's not FDA approved, so I wouldn't ask you that because it's not FDA approved. That's an off-label indication. PANTS would also not ask you that. Your PDE5 inhibitors, we haven't seen anything yet to show, so these are what we were using for our males. This is not for our females. Your dopamine agonist, this is going to help if your patient also has Parkinson's disease, which could be why they're having sexual dysfunction. So if you see that, this could be a potential thing for your patient to use. Okay, 2 birds, 1 stone. Your flubanserin, this is the one that I told you is the only one that we have approved right now, and then you have several herbal supplements. Again, not FDA approved. Anytime you see a herbal supplement, so if somebody wants to try it, up to them. But this is the only thing that you will have the power to prescribe. Is going to be your flubanserin, and then if somebody has Parkinson's, potentially a dopamine agonist, if that is the underlying issue. So when you're looking at our mechanism of action that we have, okay, just the only one that we're going to talk about is our flubanserin or our AD. Agonist activity, antagonist activity, and you see that we're still hitting our 5-HT different subtypes. So 1A is our agonist, and then you see our 2A is the antagonistic effects, right? You see that we have some activity with several different subtypes. If you remember these first 2 up here, good enough for me, agonist, antagonist, alpha, 1 alpha and 2 alpha, you're fine. But you see that we also can have some dopamine being hit. And this is good for if people have any mood types of things going on, and that's a big thing that contributes to sexual dysfunction in women. So make sure that you're doing your due diligence to make sure there's no other things going on. Make sure that their partnership is healthy and that they're happy, because that is sometimes what sexual dysfunction is being caused for. You're prescribing this, that's not going to make that change, right? They're still, if they're unhappy, they're still going to be unhappy, right? They're still dealing with the same person. So find the underlying issue with you prescribing any of these medications. So our clinical use, they're usually going to be your premenopausal women, and then they have hypoactive sexual desire disorder, okay? So again, it's just the lack of desire from wanting to have sex. It's not making them like want to, like it's not, we don't have erections, right? So it's not the same thing, it's more of a desire thing. So make sure that you're understanding what it is that you're actually treating for these patients. Again, making sure, this is what I already talked to you about, that everything underlying is okay, their relationship is okay, their mental state is okay. A lot of this is sometimes just having conversations. And then again, making sure that their hormone levels are okay. Because if I'm having pain when I'm having sex because I might be perimenopausal, or maybe I'm going through menopause, that's something completely different that you're treating, right? You're not using this medication for that. And then looking at this for your postmenopausal patients, or if they're a male, we're not using this again. Perimenopause, okay. Postmenopause, not okay. And then you see that this isn't enhancing sexual performance. So this isn't making somebody like swing from the chandeliers if they're still like upset about whatever is going on, right? So make sure that you understand what this is for. I'm being serious. That's what some people think to use this for. It's not making them hypersexual. It's not doing anything to their activity, whereas when we talk about males, that is what it is for. It is trying to help them with their sexual performance. Adverse effects, same type of hypotension type of adverse effects that we saw before. So anything around this, just think about hypertension, dizziness, okay? Contraindication, if they're also using alcohol, right? Because we already said that that causes hypotension, but we also can see where it doesn't make some people want to have sex. And then your CYP inhibitors, you remember that, that's good enough. And then you don't need to worry about the dosing. I will hang a, oh my gosh, a memory jog. I will hang that later on for you guys for this one. Take 10 minutes and then we'll come back and we'll do the pregnancy.
With a mom.
I wouldn't want to be surprised. It's just, it's an odd topic, and it's a very odd position for that.
So that person, stimulation, like that's why
No, I heard someone else, I guess, I wouldn't be, but so I was trying to have this, I had a favorite reason that like in regards to relations, so that's why I so as I'm doing I wouldn't want to be. I like to know what's going to happen. So I wanted to clarify. I'm not trying to kill I was curious, what are you doing with it? To warm for the variations? But more or less, would that change your temperature? This is not huge. So that was really kind of what I was asking. Just put it on like that. So
I did a ERP, so
that was really my question was not Let me clarify real quick.
Bro, that is a mad insert. That is a mad route there.
it was like 2 slides to get to that same thing.
Look, I know some. I'm sure some people do it. I just don't.
Yeah, boys are like, is this like a throw?
Left or right, just to make sure you know what it's. I didn't remember. Maybe that's why. Maybe that's why you said all That's like why. Nobody was the one who put him on the screen.
Alright, so our last lecture that we have is going to be our medications in pregnancy lecture. So I'm gonna, oh, did I say okay? What is this?
Yes.
Wait, I don't know, one of them, let's see what happens. What's this? Okay. Alright. So our medications in pregnancy. This one, what we're gonna go through is stuff that you've already seen before, highlighting the bigger concepts, and then going through how you're treating the most common thing, which is your nausea, vomiting, and understanding the difference between them having nausea, being nauseated, and actually vomiting, which is when they're throwing up, okay? Like two different things, okay? And you're treating them in two different ways. When you look at this, you're gonna remember our pregnancy categories that we talked about. We have our old one, which we'll still see used quite a bit, but remember we have our new PLLR. And then looking at the PK changes that happens. So this lecture, a lot of the things that I give you like pathophys in the beginning, these are also potential questions now in this lecture. So I'm telling you because it's a little bit different, okay? So I can ask you what are some different things that could affect the way that the drug is being metabolized and processed in the pregnant woman, kind of thing. And then looking at the review again of some of our different meds that we have. We talked about cough and cold, we talked about diabetes and what we prefer to use in these patients. So again, just a quick review, and then I'll focus on main drugs that I want you to look at as we go through those charts towards the end. So when we look at the factors that are going to affect our fetus being developed, we think about, again, you have the host, which is the mother, and then we have the baby that they're developing, okay? Anything that they put into their body could potentially reach the fetus. Some of it may not. The level and the amount in which reaches the fetus can also be different. If that exposure does happen with some of our medications, you can see that we have abnormal fetal development. We have different things that can happen, whether it is a physical abnormality that can happen, whether it is a growth abnormality that can happen. So just think about it's going to negatively be affecting the fetus. Then you have teratogens. So with our teratogens, these are things that can actually potentially harm, kill the baby, right? Which is something that you don't want. So you have thalidomide, and this is one of the first ones that we saw that made us kind of pay more attention to our medications, labeling our medications, making sure that pregnant women knew what was safe and what wasn't safe. You have your isotretinoin, which we already talked about, right? So these are some different defects that the child can have. Your valproic acid, warfarin, our ACE inhibitors that we have. We talked about several drugs. These are big ones that you can see causing a lot of issues for our patients and being teratogenic. The timing of exposure. So depending on when the patient takes it, they can potentially have issues, and those defects or abnormalities that can happen, and sometimes terminating the pregnancy that can happen will vary depending on when they take it. So there's that very busy chart, and it shows the fetus growing, and it shows 0 weeks, and then it starts going through the weeks. It's telling you all the different body parts that are being made at that time, and certain medications can affect that formation of whatever that body part, that organ may be. Okay, so the timing matters. That's also when you're reading package inserts, when you're prescribing, if you have to prescribe something to a pregnant woman, you need to figure out what week are they? Hey, what gestational state are they in? What's the gestational age, right? Because certain medications I can say oh, you can avoid this in the first trimester because of what's being formed at the time of the fetus, but you could potentially take it in the third. Or I have certain things where I'm like, you can take it in the first, but you can't take it in the third. Okay, so make sure that you're understanding gestational age and the timing of the exposure. The intensity, so again, this is just like the dose, the route that you're giving that patient, if it's bound or not by plasma, all of those things come into play because now I have maybe increased another drug that that person may be taking because they're pregnant, or I have maybe now increased how much could potentially cross the placenta and get into the baby circulation, okay? So all of these things make a big deal, and we'll talk about those. And then the variability of response, this is just saying that everybody is different. There's different genetic makeups, and some people will respond to certain medications in different ways. And if we don't know the genetic makeup of that fetus yet, that's why some of our meds, like when we talk about G6PD deficiency and things like that, or if we were worried about G6PD in the host, we of course should not be doing that if they're pregnant because we don't know if that baby is G6PD deficient or not, and then that will affect their life and if they can make it, right? So all of these things kind of come into play with our children. When we're talking about thalidomide, this is one of the things that I told you was teratogenic, and this was something that was used back in the 50s, and what they were using it for was to help with nausea in pregnant women. But what they found was that when the women were delivering their babies, they had these abnormalities. And so they were having these developmental effects, and so they started to study them, and we were seeing like, oh, okay, well maybe this is being caused by the medication. So now, definitely not something that you'll see us using quite a bit at all, but this is what we were using it for before. Now we don't use it in pregnant women because this is what's happening to the kiddos. All right, so this was the chart that I was telling you about, something for you to just note. I don't need you to remember what's happening at what time. But essentially this is how you're saying, hey, what could be the risk or what could I be potentially harming if I expose them to this medication at this time? So this is just showing you what's developing as that child is developing. So again, what I expect for you to know is that you're gonna say, oh, this person is pregnant. I'm gonna go and I'm gonna look it up and say, is this allowed in the first trimester? Is this allowed in the second trimester? Is this allowed in the third trimester? That's all. This is for you to look at later. I'm not asking you questions about that. Again, you've seen this several times. This was our old way of classification. This is what you'll probably still hear when you're out doing your phase 2 and when you're practicing. So category A, B, C, D, and X. X is like, I don't do it. It's very teratogenic. We have like our retinoids, our statins, thalidomide, things like that that we were looking at. And then category A is your best case scenario. Category C is saying like, hey, I don't have data to show me either way what I should be expecting. And then D is like, we know that there's some fetal harm that could potentially occur if I gave this to the mother, okay? So best case scenario, these are like your worst case scenarios. When I teach you guys and when I've been teaching you, I've been telling you like, I stop at this. If I don't see an A or a B, I'm like, I'm good. I'm not trying it, okay? Unless I absolutely have to, I will push to a C. This is your PLLR, your new rules. So again, remembering these subsections like you did last semester. If you still remember, great, one less thing for you to study. So we have our 3 different subsections. You have your pregnancy, your lactation, your females and males, and reproductive potential. And so this is how now, if you prescribe something and you open up that package insert, you go through it, you should see these 3 subsections that will help you know if a patient is eligible to be taking this medication, if it is safe or not for them. So when you're looking at your pregnancy, again, just giving you what the dose should be, if there's any risks that could be potentially happening. And then it has those 3 subsettings, your risk summary, your clinical considerations, and your data, which is also in your lactation subsection. And this is just saying, hey, if I'm breastfeeding, can I use this medication safely? Is it gonna pass to my baby while I'm feeding my baby, right? And then the amounts of which that would pass. And then your females and males of reproductive potential. This is just saying like, hey, if I'm trying to conceive, if I am and I'm wanting to know, is this medication going to harm my, my child that I'm trying to make? Can I take it safely or not? So this is letting you know, hey, do I safely use this? Do I not? Like how some of our drugs that we were talking about, where it said, oh, wait until 1 cycle, wait until 3 months, don't get pregnant in that time frame kind of thing. This is what this will give us. Again, we have a lot of data for our females. We're still kind of lacking and building up on the male side of that and getting studies for that to say like, hey, if I'm trying to become pregnant, like, is this a big deal? Is this not a big deal? We're still building that up, kind of late. All right, our absorption. So when you look at this, you see, I want you to focus on the things that are in bold. Underneath it is just giving you more detail about what's going on, right? So when you're looking at absorption, think about like the meds kind of staying in there for a longer period of time, depending on what's going on. So they have decreased gastric emptying and motility that's happening at that time. So if I'm not emptying as quickly, you can see where sometimes I can have now a higher Tmax occur with the medication than what I would have typically been expecting because it's sitting in that one area, getting broken down for a longer period of time. Your increase in gastric pH could be happening, and then again, that's for several different reasons. So if you have a drug that needs a certain type of environment to be absorbed or to be broken down, the bioavailability may be affected by this. That's why this is important for you to know, the increased gastric pH. Nausea and vomiting can decrease absorption. So if I'm sick and I take a medication and I'm feeling nauseated today because of my little human that's growing and I throw up, I probably threw up some of that medication. So therefore now, again, now I'm decreasing the amount of medication that I have available. So what we do in these situations, if we know that the nausea and vomiting peaks at a certain time of day, we'll tell them to take that medication at the time where it's least likely to occur. Or we can find a different formulation, right? So I can give them something that's sub-Q, I can give them ODT, I can try to give them something rectally. There's several different ways that we have that we can potentially give our patients a medication that they may need if they can't tolerate even swallowing a pill. Inhalation, just understanding that again, I can have increased drug availability if I have the inhalation formulation, and in my IM delivery, I may have more absorption whenever I'm looking at my IM dosing, so that might have to be decreased in my pregnant patients, okay? So again, pay attention to what is happening with each of these. You're looking at your bold, I have decrease, I have an increase in my pH, I have a decrease in absorption because I could be potentially throwing up my meds, I have increased absorption within, so write an up arrow so that you know this is increased, and then again with your intramuscular delivery, increase. So write another up arrow, okay? I won't go into super detail like that on the sub. So just write up and up on your inhalation and your intramuscular. Distribution. There's more water whenever someone is pregnant in the body. So with more water, I can have more distribution. I can have that plasma volume is now increased, right? Because I'm trying to also perfuse that baby, and I have to make sure that the baby circulation is also fine. So total body water goes up, your albumin concentration, that is going to change. When we're looking at this matters with drugs that are going to be bound. If something is not albumin bound, then it doesn't matter. So again, whenever I'm bound, remember I'm in a relationship, I'm not doing anything. Whenever I'm unbound, I'm out and I'm wrecking havoc, right? I can have activity. And so when you're looking at this, just make sure that you're paying attention. This one, read under here so you can understand what's going on. So decrease in my albumin concentration, decrease in albumin bound drugs because now I have less. Is this different than what y'all have?
We don't have percents. They're all different.
Yes. It's a little bit.
Okay. Y'all have all the slides? Does it say?
Decreased albumin concentration is fine.
Hold on. Huh?
Very similar, just like a few different things.
Same.
Hold on, it's not going into presentation mode.
They told me the same thing. They told me the same thing. So I guess they're getting away from the
Okay. I tried to make it clearer, and that's why. Okay. So decrease, right? So if I have decreased albumin and something is albumin bound, then I have now more free drug. So therefore, I may have to alter or change the dosing that I have for that patient, right? Because now there's more drug out that can do the thing. So rise in your free active drug concentration. So again, I don't have anything to bind to anymore, okay? Body fat increase. Now, this should be in a certain amount. It shouldn't be something that is very drastic, because if it is increasing a lot, remember when the baby comes out, then they have to lose all of that, right? So just make sure that you're letting them know that it should be, and it should stay around this amount, the 4 kilograms. OB is very good with staying on top of that, making sure that people are actually gaining how they're supposed to, because some people lose weight during pregnancy, right? So you're supposed to stay in a healthy range. So just make sure that you're understanding that this body fat is supposed to increase during this time. And then your metabolism, you have your P450, right? We talked about all of our SIPs. And so you can see that depending on what's going on with the hormones, you can have induction, you can have inhibition. Just understand that your SIPs are going to be affected as well. And then your rate of metabolism is going to change because of that, right? So depending on what's going on, depending on if it's a regular, like my pro drug, or a regular drug, all the things that we talked about with last semester, same exact principles are here, telling you metabolism will change. And then looking at your elimination, you see that several pregnant people, especially as they get later on in the pregnancy, you'll see that that blood flow starts to increase, their GFR starts to increase, they start increasing how much they're going to the restroom, okay? And you're also running out of space. So you'll see that this elimination, depending on what's going on, depending on the drug and where it's being absorbed and how it's being absorbed, you can see that that maximum concentration can also be sometimes decreased because I'm excreting it a lot more. I'm going to the restroom a lot more, right? It's going through my system a little bit faster. All of these things that we talked about vary as they're going through pregnancy, okay? Depending on which stage of pregnancy they're in, you'll see different effects going on throughout the body. So just know that these are different PK parameters that can happen. The drug transfer. So this is what I was kind of touching on before. All you need to know is that babies can be affected by the drug that the mother takes. Sometimes in greater quantities, sometimes in lesser quantities, okay? It just depends on what's gonna pass through that placenta. So your job is, if somebody is pregnant and they somehow land in your clinic, look it up. That's what I want you to know, okay? So all you need to know is that there is drug transfer. That's it, okay? Don't worry about anything else, just drug transfer occurs. All right, so when we talk about nausea in pregnancy, sometimes this does become where someone is vomiting, but it could just be that they're nauseated and we have our morning sickness that can happen. So when we talk about treating this, you have the starter pack that we typically will give people. We'll tell them to make sure that they have a brat diet, which is like bland types of diet, bananas, rice, applesauce, toast, just very bland types of things to not want to irritate their stomach, upset their stomach. Also trying to just avoid oily, greasy types of foods because that can sometimes make it a little bit worse. So brat diet, avoiding triggers, making sure that they're staying hydrated is a big thing because a lot of the times if someone is not hydrated, it can cause contractions for them to start occurring, which then would make them feel like they're nauseated sometimes or like they have to vomit. So again, making sure that the hydration is occurring, and then prenatal vitamins. That's where you come in because you can prescribe prenatal vitamins. If you know that someone is trying to become pregnant, you can also be prescribing prenatal vitamins to them, okay? So that they have their body already ready, and that way they don't have to get ready whenever they get pregnant, okay? They know they're trying. Now, if they have nausea that's occurring, there are several different ways that we end up treating this. There are several different medications that we go through. And so this is where we kind of start. And sometimes this is the first thing that you're going to give as soon as you find out somebody is pregnant, which you could be that person who's telling somebody like, oh, here you go, you're pregnant. They came in for regular labs and found out there's a baby. So, ginger and pyridoxine, so your B6. This is something that you can have your patients take. We do have it in the pharmacy. The pyridoxine, the ginger, they would have to get, but you can have them try just one, or you can have them take it together. This is like just the very basic starting off thing of what we can do for our patient to kind of help them whenever we're talking about nausea. This is not for your patient who is experiencing so much of that vomiting. The next step that we have, and this is what we do have in the pharmacy, so if they're taking the B6 and they're taking the ginger, that's not working, what we have is doxalamine. And usually what we would do is we have the pyridoxine and the doxalamine, both of which you can prescribe, and they usually take those together. And that helps a lot with the nausea that they're feeling, and it decreases it quite a bit. If they're not having any response at all, no response at all, then you stop all of this that they're taking, and then you'll start an antihistamine. If they were saying, hey doc, I have some relief, then you can add the antihistamine to what they were already taking above, okay? So if I got some relief, don't take off the thing that was still working, just add the antihistamine to complete it because they didn't have full relief. But if they're getting absolutely no relief at all, that means that it's pointless for them to take it. You're just making them take something else. Just put them on an antihistamine and see if the antihistamine works. This is for when it's getting more serious, whenever they're starting to have some of the vomiting and everything happening to them. And then that's when we start to add on our dopamine antagonists that we have. So you have your metoclopramide, promethazine, or your chlorpromazine that you can add. And this is, again, your vomiting at this point. This is not just nausea. Okay, so nausea is above our red line, vomiting is below it. That's still not working, then we can add on our Zofran or your ondansetron, and then if that's still not working, then they would be likely admitted, and then you'll be giving them steroids to try to help them. We do have some medications that help with people who have hyperemesis that sometimes are covered by TRICARE, sometimes not. You have to get kind of creative to help these women who have this. So just, again, remember this, you are going to see this again, okay? So their diet, avoiding all those things, yes, basic, non-PHARM, they make sense. But remember the order in which you're trying to help your patient and the progression that will happen. This is just a chart of what we just talked about, and it's going through the same thing. So if you like to see a picture, then this is a picture form of that, but same exact thing. Going into these drugs individually so you can know more about the medication. So our ginger, not FDA regulated, right? Something that's over the counter. Good for our nausea, not so much for our vomiting. Also, some patients choose to eat it, which is another option. They do teas, several different things like that that don't have caffeine in it. But if they can get ginger in any other type of way, this is also something that's very good. Don't need to remember the dose. Looking at your pyridoxine or your B6, this is good to help again with that nausea, and most of the time we're combining it with the ginger or our doxalamine. And then you see your mechanism of action, essentially just helping with the functioning and the precursor, providing itself as a precursor for a lot of our different fats, proteins, things that we need in the body to just function. And we found that it helps with decreasing the nausea in our patients. Again, don't worry about the dose. Adverse effects, the higher the dose, you can see that you have neuropathy that could potentially occur. So when we give this, it's usually a smaller pill, and depending on if we added the antihistamine to it or not, sometimes we will cut this in half, to have them take less of it, and see if we can get more of the benefit from the antihistamine. So we kind of play around with this dose, it just depends on what's going on. Again, whenever you're trying to prescribe for this, just look it up, making sure that you're not getting to a very high dose. So understand neuropathy can occur at our higher doses. This is another non-PHARM thing that we have, which is going to be your pressure point or acupressure point, and essentially it's 3 fingers up where the pin is. You're supposed to press on it, and what we know about it is that it's supposed to help relieve motion sickness, and so they also say that it is found to potentially help with a lot of the nausea that some of our patients experience who are pregnant. So again, just 3 finger rests above where their wrist fold is, and that's supposed to help decrease. And you also have those bands that they say that you can wear, and it kind of sits on that pressure point as well to try to help decrease motion sickness and nausea as well. Your doxalamine, this is one of our antihistamines that we have. Remember, your same mechanism of action when we talked about antihistamine is the same exact thing here. And then what it's trying to do when we're talking about nausea is it decreases that vestibular stimulation, which is why people feel the nausea in the first place. So it's helping in that trigger zone. You see here, moderately effective. We have nausea and vomiting coverage, and what we're usually doing is going to be your pyridoxine, which was that B6 that we talked about, with your doxalamine. This is called diclegis if you have it in a combination. This is, again, a TRICARE formulary lookup tool type of thing, because sometimes they will pay for it, and then sometimes they don't. Most of the time they don't. So the way that we get away with it, we just prescribe these individually and tell them to take 2 pills. Okay? But this is a great option if they're covering it at the time. Okay? And then the previously removed from the market, this was the doxalamine. Not something that we worry about anymore. With that, just understand that it was something that was there back in the day. Looking at, again, your steps. These were the steps that we talked about. So your doxalamine and your pyridoxine, we would already have those on board. So if there was no response to your pyridoxine or your doxalamine, then you would discontinue those and you would just put on the antihistamine. If you had a partial response to your doxalamine and your pyridoxine, you would leave them on and add an antihistamine to that, and then you can add on a lower dose and kind of build your way up. Pregnancy, you're already tired, you're adding an antihistamine. Granted, it is a low dose, but some people are very sensitive to antihistamines, and it could cause drowsiness. So that's why you're hoping that they at least had a partial response, because then I can decrease the amount of antihistamine that I'm giving them. I can give them half a dose, and if they're still saying that's not helping with the nausea and vomiting, then I can try to increase it and hopefully stay away from the drowsiness that they'll experience. You have your dimenhydramate, your diphenhydramine, which is your Benadryl, and then your meclizine. You see that if I am going to add on my diphenhydramine, because of the increased drowsiness that I can definitely see when I'm using this, then I would want to stop my doxalamine before adding on my Benadryl. Okay. Increased side effects, it just makes it worse for your patient. So in this situation, you would replace your doxalamine with your diphenhydramine if you're going to do that. Don't add them both on. Increased side effects, increased nausea and vomiting, which then defeats the purpose of us giving it to them in the first place. Okay, so that's why specifically with your Benadryl, you see that if I did for whatever reason keep my doxalamine and my pyridoxine, my B6, that I would stop the doxalamine portion of it. And then your meclizine, you will still see this used sometimes by OB, but what we saw was that it did have an increased risk of cleft palate in rats, and so not something that we prefer as much anymore. Looking at our dopamine antagonists that we have, so you have your metoclopramide, promethazine, and your prochlorperazine or your compazine. And what you would be doing here is you're picking just one of these medications, okay? So you're not putting on multiple because there's no reason for you to add on the same drug class, right? You're just increasing the side effects. So when I'm looking at this, I'm trying to help promote the emptying, so that way they don't feel so full, they don't want to have that nauseating or that vomiting feeling like they're gonna throw up, okay? So, stimulate gastric motility and emptying to decrease those emetic effects that they may also be feeling like they're gonna experience. Of course, you see that we have some sedation with them, your metoclopramide, you see that you have more TD, the same things that we talked about last semester when we were talking about Parkinson's. So the longer that you see that these symptoms are happening, if you don't remove that medication at that time, or if you don't counsel your patient that may happen, you can see where they're irreversible and there's stuff like that. Your promethazine, especially if somebody already has seizures, you see that this also can decrease that seizure threshold, so this is a bigger thing that we want to worry about and make sure that we're monitoring. And then, again, we already talked about your compazine, same side effects, right, as your promethazine, but you see that we also have malformations that could occur. So big thing that we're looking at here is when you're putting these on, make sure that you're monitoring your patients, because there are several things that can happen that are unseen that could have irreversible effects for the baby as well as the mother. Looking at your phenothiazines, you have, again, this is just the breaking up of it. Don't need you to remember that it's a phenothiazine. As long as you're remembering I am talking about my antagonist, you're okay. Again, same exact things that we already talked about before. When you're looking at your promethazine, you see that your promethazine, that you have your motion sickness. That is also a big reason why we typically are using promethazine, but we can also use it when we're talking about nausea and vomiting in our pregnant population. Mechanism of action, same things that we kind of talked about before. Big thing and the big benefit when we're talking about the nausea and vomiting is going to be that CTZ center, and us trying to decrease that nauseating feeling that they're having and potentially the vomiting. Your sedation, of course, is going to happen just by way of our mechanism in that drug class. And then looking at your use, we already talked about the nausea and vomiting, and you can also see that we can pre-treat in our patients who have the chemo-induced nausea and vomiting. If you don't remember that CINV. Adverse effects, EPS symptoms, because again, our mechanism, we have that blocking of the dopamine, hypotension, restlessness can occur. So just make sure that you're paying attention to these things. The sooner that we catch it, the better change their medication for them. Drowsiness is going to be kind of hard in any of these meds to distinguish because they are pregnant, and sometimes pregnant women are sleeping, a little drowsy. Your persistent nausea and vomiting, so this was as it was getting more serious. I couldn't deal with it with like my basic, less harmful medications. You see that you have your ondansetron or your Zofran. With this, the safety of it is kind of unclear. OB still does use this medication. They don't want it to be something that a person is having to use every single day. The good thing about the Zofran too is that it comes in a ODT formulation and not just a tablet. So if somebody is experiencing like or having a bad gag reflex while they're pregnant, they can just put it underneath their tongue and it will dissolve. It does have like a pepperminty, like funny kind of taste that some people will say also makes them feel like they have to throw up because they're sensitive to smells and tastes while they're pregnant. So just kind of see how your patient responds to it. If they can swallow the pill also works pretty good also. Your adverse effects, you see here that you have the QT prolongation, everything else is kind of common, right? Your constipation, drowsiness, all of these things are, again, things that are happening already in pregnancy. And then looking at the fact that that first trimester, so this was what I was telling you guys about, that chart with how the baby is being formed and how they're changing, and you have different organs being formed at different times. So in the first trimester, whenever we were giving Zofran, which is usually when people have a lot of morning sickness, it usually goes away mysteriously after that first trimester. Hopefully in some people it continues the entire time. But you see here that we saw that they had some malformations that were occurring in the oral clefts or something as well. So again, this is what I mean by looking at the package insert and saying, hey, is this safe for me to use depending on this trimester? And this one is one of those ones where it's like, gosh, I would like to use this in that situation. I can see two different things happening. I can see congenital, or I can see that these cleft. So I don't have the congenital happening, but I do see where they can have a cleft palate. So it's kind of a risk versus benefit thing, and talking to your patient to see if they want that to be something that they're exposed to, or if they want to just deal with the nausea and vomiting that they're having. And at this point, they would be vomiting. Okay, so it just depends on how often they're doing that. And then looking at your Ganacetron, this one is an older medication. I don't see this used a lot. Just understand that it's there and it's something that could be potentially prescribed. Same kind of side effects that you see with your Zofran. Our steroids. So we talked about steroids already. You have your methylprednisolone, hydrocortisone, prednisone. Prednisone is the one that we prefer. If they're still refractory and they're not responding to the prednisone, then that's usually when you see that we'll go to IV methylprednisolone. And then sometimes they'll follow up with like an oral taper of the prednisone to kind of, because they're going to give them a higher dose because they didn't respond in the first place. So prednisone is kind of what we like to use in this situation. If they're refractory, you will see us kind of go to the methylprednisolone. But just know which steroids we're using. Sometimes we can still give this orally, but if they're vomiting if they're vomiting a lot, then we end up doing IV for them, okay? And that, of course, will require them to end up being hospitalized. They would go to OB. OB usually will start dealing with that. It won't be something that you're doing. First trimester, again, you see that we're avoiding them because of that cleft palate. And then looking at your adverse effects, just understand the same things that we talked about with our steroids. They exist in our pregnant women. Again, more likely to be exaggerated because all of those PK changes that we said happen in our pregnant women. All right, GERD. When we talk about GERD or gastroesophageal reflux in pregnancy, it is something that is bound to happen. The longer the pregnancy goes, the bigger their belly is getting, the less room that they have for food. So we usually can avoid this by saying, hey, eat smaller meals. Make sure that you're not aggravating it with like acidic or spicy things because that can increase that reflux that they're having. And then elevation of the bed, not eating very close to bedtime where they're going to lay down. So you can kind of prop them up with pillows and tell them to put pillows behind so that they can kind of sit up and not feel like that pressure and that burning that they'll feel with the GERD. Our meds that we have are things that we talked about last semester: antacids, sucralfate, your H2 antagonists, proton pump inhibitors. All of these things are here. We're going to go through some of them. When we're looking at our antacids, pretty safe when we're looking at pregnancy. Just make sure that you're not picking anything that has aspirin in it. You see that your aluminum can be cause constipation, which they may already be experiencing with the pregnancy. And then you see the magnesium will make them go. Magnesium is more so associated with diarrhea. Your sucralfate, again, because it's something that's not well absorbed, is typically safe in pregnancy. And the way that it's working or its mechanism of action is essentially trying to say, hey, let me protect that gastric lining and try to make it to where they don't have that burning that they're experiencing with the GERD. Okay, so helping a lot with that acid that's in their stomach, neutralizing that. So antacids, sucralfate, safe. Adverse effect of something that has aluminum is that it can have the constipation, and if you're looking at magnesium, it's going to make them go diarrhea. Your H2 antagonists, when we look at these, you have cimetidine and famotidine. Cimetidine is the one that previously had like the most research, and so that was the one that we said, hey, we're going to go with this one because we know that this is the safest option that we have. But we do now see a lot of famotidine being used as well, and is gaining more research and popularity to where you may start to see a shift in the use of the cimetidine because it does have a lot of side effects. Looking at your proton pump inhibitors, likely safe, doesn't have as many studies. So again, this is something that if I see that, I'm going to say, hey, OB, what do you think? And then you see it excreted in our breast milk, and then omeprazole is the one that we typically are going to use the most. So I underlined that one for you to use. Remember omeprazole. Looking at constipation, again, something that is very likely to happen in our pregnant patients, so make sure that you're telling them to make sure that they stay hydrated. Hydration is a very big thing. And then you have your fiber, and then moving around, making sure that they're exercising. The more that they stay still, the more likely they are to experience that constipation occurring, okay? We have several different options that we can use. So your bulk forming agents like your fiber, these are the things that we typically would like to go to. Again, they can experience the bloating and the gas as our side effects. You see that we have a stool softener. Sometimes people may not want to go to the bathroom, or they'll hold it because it hurts for them to go to the bathroom. So if your patient is complaining that it's harder, again, make sure that they're drinking enough water, but you can also add on that DocuSafe for them. You also see that we have our magnesium, hydroxide, lactulose, and our PEG, or our polyethylene glycol. Again, these are all things that could be safe, making sure that they're still staying hydrated again, because you can have those electrolyte imbalances occur, especially if they're using that magnesium and they're having, they're going to the restroom, right? So they're getting a lot of that fluid out, and if they're not replenishing it, then you have electrolyte loss as well. And then your stimulant laxatives, these are more like a last line option that you can give your patient, okay? Because, and especially if they're later in pregnancy, it can cause cramps, right? So if a stimulant laxative is very aggressive, and hopefully that's not something that you will have to use in a pregnant patient. So for this, just put that it's last line, likely safe, but again, this is like your refractory case of you having to use something in a constipated pregnant woman. Because of those cramps, we don't want to, these will be more aggressive cramps than what you'll see in your bulk forming, okay? Your bulk forming is more like an uncomfortable, and this is like I'm stimulating you, I'm trying to make you go, and you don't want that happening when somebody is pregnant, especially towards the end of their pregnancy. Diarrhea. So when we're talking about diarrhea, not a very common problem, but again, we need to make sure that they're hydrated. You are likely to see the constipation. You do have loperamide that we are typically using for this, but it's very inconclusive on if it is safe or not in pregnancy. So again, this would be something that I would defer or try to get in touch with OB to ask them about it. And then looking at your business subsalicylate, not recommended. Why? The salicylate, right? Okay, so looking at that, making sure you understand we don't want to typically use that. Some other issues that we have in pregnancy. So pain and fever, Tylenol, okay? Long story short, Tylenol, all right? Everything else is a no. So if you see something for pain, acetaminophen. That's all this says, yes, bless you. We don't use NSAIDs, Tylenol. That's all you know, Tylenol, okay? Yes, there are studies that are coming out about the ADHD, and we're hearing announcements about all of that. Per this exam, per our textbook and our reference, Tylenol. Cough and cold. So when we're looking at cough and cold, you have your antihistamines and we have cough suppressants. We already talked about Benadryl. Benadryl is popping up here again, right? So most likely it's very safe for us to use. We typically will see this being used, but again, watching out for the drowsiness that could occur. And then looking at this, you do have your loratadine and your cetirizine that are being taken in pregnant women who are already taking them before. But again, something that is gaining more popularity now that we don't have a whole lot of research on. So Benadryl, first thing that you want to use, potentially your loratadine or your cetirizine. Cough suppressants, if you absolutely had to, this is something that I have seen OB do. You have these options. We don't like to use them at all because if they're using them for a very long period of time, we also have the metabolism when we're talking about our codeine. You can see withdrawal that ends up happening in the fetus because the fetus is also going to be exposed to that medication, right? So we definitely don't want to use this if we don't have to. This is something that if I had a patient, I would definitely be referring them if I were looking at one of these or a cough suppressant. You have your guaifenesin. Again, very little data A lot of people say that this doesn't work anyway, but it does. It's an effective medication. It does have an indication for a cough suppressant, but again, limited data. And then your benzonatate or your Tessalon pearls, not enough data. So in this whole category, you don't really have great options. For cough, I would refer them to OB to let them pick what they want to for that. All right, your sneezing, rhinorrhea, so runny nose, throat pain. We talked about saline, right? Doesn't really have anything in there, so they can flush themselves. They can have the gel formulation. We have it in the pharmacy. You can order it for them. When we look at our decongestants, we talked about the fact that it can increase blood pressure, a lot of them that we had. So with that, just kind of keep that in mind. Remember, this was our least effective one that we had, that phenylephrine. There are some times where I see OB allow this. I had to use this. I was on a plane. I think I was in my last trimester of pregnancy, and I was super congested, ears, and I was like, I have to get on the plane, and I can't breathe, and I can't hear anything. I need something. And they say, okay, yes, because I was only going to take it for that day to just get through the flight, right? So if you're not taking something for a long time and you're taking things as one-offs, it's typically going to be okay. Because their body is going to re-regulate and it's not going to stay in there for a long period of time. So just, again, something that could happen, just make sure that you're watching out for it. It shouldn't be something that you are prescribing, again, OB. But in this, you see that first trimester, just make sure that you're avoiding it within that first trimester. And then it's in very short-term use, which is the same things that we've already said about using these decongestants in the first place, right? So same rules are applying in this situation. Okay, some of our medical conditions that we have. I will tell you what the medical condition is. So preeclampsia is essentially because I'm pregnant now, my blood pressure has gotten higher. That's all you need to know is the word, preeclampsia. Let's talk about how we're going to treat that, okay? So when we're looking at this, you have our different medications that we're gonna try to give them, and also for lifestyle modifications. What are you eating? Making sure that they're, again, drinking their water, still trying to work out if they can. So if somebody has chronic hypertension, we talked about the Lifetime Movie Network, so labetalol, methyl-dopa, and nifedipine is like your third line type of thing that they could be on chronically during that time. If you have a hypertensive, urgent, emergent type of situation that you're trying to control, you have labetalol again, you have nifedipine, and then you have hydrolizine that are different options. So this is just my everyday, what I would be taking type of option that I have for my patient. This is like, they came in, you still see that they're taking their daily dose, but they came in and for whatever reason they're still elevated. I might have to use an IV formulation of this or give them a higher dose at that time to try to control their blood pressure, okay? So they're gonna get monitored quite a bit if they have preeclampsia by OB. This is for your awareness to know that these are the different options that your patients have. Or if you have a patient who is, who you find out they're pregnant when they're in for your office visit, if they're taking something else for hypertension, you can switch them over to one of these meds, okay? That would be what your job is going to be. Don't leave them on any other medication. Get them switched to one of our medications that are safe in pregnancy. Looking at eclampsia. So your eclampsia, this is like now more serious. They could be potentially having seizures during pregnancy. They're also exposed to this after they deliver the baby as well. So now our issue is that we're worried about seizures. So in that, we have our magnesium sulfate IV that we can use, and this is our drug of choice whenever we're talking about our patients who have eclampsia. Now, I don't need you to remember any of this dosing or any of that. What I want you to know about this is that you can potentially give this to someone if you know that if they have eclampsia. You can give this to them even though they haven't experienced a seizure when they're delivering, because you want to prevent it from happening. So this doesn't always mean that you have to give this like after they started seizing. Sometimes you will see this prophylactically being ran as well. So I just want you to know that it is the drug that we're using to prevent, them from having a seizure, or if they're having a seizure, this is our drug of choice that we're going to use in that situation. If you gave them too much, so if they were to have some toxicity, which looks like them having like muscle weakness, confusion, a coma, if you gave them that mag sulfate and they had too much of the mag sulfate, you would need to give the calcium gluconate to kind of counteract that toxicity that they would be having, okay, that muscle weakness, and reverse all of that. So, drug of choice for eclampsia. All I need you to remember is eclampsia, what our drug of choice is, and what the antidote is for it. And remember your route of administration as well. Okay, HELP syndrome. So HELP stands for your hemolysis, elevated liver enzymes, low platelet count. Again, just remember HELP syndrome, and then your treatment. What we're doing in this situation is we're doing supportive care. We're prophylactically trying to treat seizures if we know that they're going to be predisposed to that, because everything is out of whack at this point for this patient. Steroids, very controversial on if you should give it or not, so that would be left up to the specialist. Transfusions, all of those things. And then sometimes, depending on how bad it is, we may have them go and deliver that baby early if we can't control it. And depending on the medications that we're thinking about giving, we may deliver the baby early, okay? So most of the time, that's why you see this consider delivering at term. So in this situation, just understand the only meds that I'm talking about with you guys are going to be the seizure prophylaxis. Diabetes, we already talked about this. When you're looking at this, make sure that you understand that you have insulin as your preferred medication. Not going to ask you any of this stuff up here at the top. This was when we talked about our diabetes lecture, right? So insulin is preferred. Remember that depending on what stage of pregnancy they're in, those PK parameters are going to change, and therefore you might need to change the dosing. You could have somebody who has diabetes before they got pregnant. You can also have our gestational diabetes, right? And this is what we would be wanting to do for our patients at that time. We want to give them insulin. And then you have your oral options that are also available. We don't have long-term data to say how safe they are. We prefer insulin, drug of choice, so this is number one. These are your number two options, glyburide and metformin. They do cross the placenta, so that is why we're worried about it. Does anybody remember which insulin we like to use? Regular insulin. Neural tube defects. So when you're looking at neural tube defects, I will tell you that there is some type of neural tube defect, and you will say, oh, they need to have folic acid. So that is why it is important whenever they're using or whenever they're thinking about becoming pregnant, and that's why I told you prenatals before pregnancy is also good, because you're getting the body ready to have a healthy baby. And so you have the folic acid that they need to take. Just remember folic acid. Don't need you to remember the dose. Prophylactically, while we're giving this, and what we're trying to do is that 3 months prior to, again, just trying to make sure that you're getting your body ready for pregnancy. And this says take throughout the first trimester. You take it the entire time, okay? Why it says the first trimester is that's because whenever you have that forming along that chart that we looked at, and they're specifying that you need to have it in that first trimester, but we do encourage it the entire time if they can. Anemia, again, we can look at different foods. So if you just remember iron-rich foods, that's good enough. A lot of red meats, fish, potatoes, things like that contain iron. So we want iron-rich foods. Remember that we have 27 milligrams a day. I'm not going to ask you that. Don't remember that. Sorry. I'm not going to ask you that. I don't want y'all to remember things like that. Iron-rich food, they need iron. So we have different supplements. You have your fumarate, sulfate, and gluconate. This percentage right here is the amount of elemental iron that's actually getting to the patient. Y'all have seen these things before. So just understand that they need, if you see furous in front of something, and anemia, that's probably what you need to be picking, okay? And iron-rich foods. Side effects. Side effects are a big deal because a lot of patients experience the side effects and they freak out because their stool is going to be a dark color, kind of like a black, tarry-looking stool. Sometimes it will also make them constipated. So with that, you need to go back to what we talked about with giving for constipation and try to start giving them some type of fiber or something to help them go to the restroom because of this medication. So most of the time when we give iron, definitely tell them to make sure that they're drinking and that they're taking some type of fiber to kind of help get that stool out. And don't freak out when it's black, because that's just the iron, okay? And that's what's happening. And then if you hear people complaining about the upset stomach, which is one of the other big complaints, they do have extended release and coated types of iron that you can prescribe, and that helps minimize how much of that GI irritation they're going to feel. Okay, medications and lactation. So when you're looking at this, this is just telling you like, hey, if the medication is safe to use in the infant and you're breastfeeding, then it's likely fine as long as the mother is okay with her child having that medication in their system. If the medication is not safe for an infant, then of course you should not do it, because it could potentially pass through the breast milk. Big thing that I want you to know here is that this is something that you need to look up. Yes, a lot of our medications do pass, but the quantity in which they pass into that breast milk is sometimes so minute that it won't affect the child. Again, look it up and talk to your patient, because some people will say, I don't want my baby to have any of it at all, okay? So, conversation. Antihypertensives. So when you're looking at this, this is the same thing that we kind of talked about a little bit before. The big ones that I want you to focus on are going to be your methodopa and your labetalol. We like methodopa because you see it's just easier, right? I don't care what trimester you're in, you're pregnant, methodopa. You're about to be a mom, methodopa, okay, with hypertension. Because I don't have to look at this. Your labetalol is lacking the first trimester. I can give it in the first trimester, second and third are fine. And then nifedipine, you see why this one was kind of a second line, I can only give it in the third trimester, okay? So these are typically the ones that we are looking at. Magnesium is just a supplement that we found that does kind of help. Most of the time you're not gonna get the control that we wanna get. So all of these down here, just know that they exist. I want you to remember these and when you can and can't take them as far as your trimester goes, okay? So just understand that these are different options that you have available. These we already talked about before, avoiding, right? ACEs and ARBs, your beta blockers, things like that. And then you see these little subscripts. This is just telling you if they're gonna cross the placenta or not. And then if you are talking about your diuretics. So this number 2. So what this is saying is if they were used before pregnancy, you could likely continue to use them, but you wouldn't initiate them or start them. And it depends on what the indication is. Most of the time, if they're using it for a blood pressure indication, we'll still try to switch to one of our top 3 that are up here, okay? So just remember your top 3 that are here. RN acids. Pretty much everything here works. The only thing that we can't is our business of salicylate because of the aspirin. Everything else, these are all options that we can potentially use, okay? Some of these, remember I was telling you, kind of would talk to the provider about it, but just as long as you know you're not picking up salicylate, you're good. Our antifungals. So this, the big idea that I want you to remember and take away from this is if you see something that says 1 a day, most of the time those are also over the counter and they're higher doses because they get to just take it 1 time. Avoid those in pregnancy because you're more likely to have adverse effects from those. If you see it in a 7-day form, those are more tolerable and they're lower doses, okay? So when you're looking at your butaconazole, no, because it's 1 day. Your clotrimazole, oh, this one is 7 days. I can take it. My conazole, tioconazole, because they're 1 a day, or your monostat, no. But if I had the 7-day, I can take it, okay? So you see that the 7-day is good, your 1 day is not. So if you have something like this, just make sure that you're paying attention to the fact that your 7 days are the ones that you want. Your fluconazole, this is something that I would talk to probably OB about to let OB decide if they want to prescribe it. If they're taking the 150 milligram dose, which is usually when you're using it for your candidiasis, if they're using it for that, most of the time it is okay. I would let them prescribe it though, or I would consult them. You will see this, it is because it's just 1 dose that they're taking, and usually they're fine, and we don't have any issues with it. But we do have other options. These just become a little bit messier because they are creams that they're gonna have to insert vaginally every night, and they have to remember to do that for 7 days. So some people don't love that, and they would rather do one and done. So that's why this says maybe. You see that the class is a C. So remember, 7 days are good, nystatin is good, maybe with different times on. This is just talking about some more of our topicals that we could potentially be using. Just steroids, we talked about this already. Our high potency, we don't use them. What do I prefer to use? In pregnancy, if I had to pick a steroid that was topical, low potency. In pregnancy, my older patients, my babies, low potency. Tretinoin, remember I can't be pretty while I'm pregnant, so I'm not worried about any tretinoin because this was teratogenic, so that's why you see the nose across from there. Benadryl, hydrocortisone, yes, low potency, and then you have the Benadryl because we use it when we're talking about our nausea and vomiting, we use it all the time. And then our antibiotics. So this was a refresher of something that you've already seen before. So in general, if I have a beta-lactam, and I will tell you guys the class, okay, so just remember the drug class if I ask you something on here. I will make you try to remember the names again of where it goes, okay? So my beta-lactams, you see that I'm pretty good here. Nitro, we already talked about, specifically with nitro in your Bactrim, that I can't use these most of the time in pregnancy, especially early on. We could potentially use them later, but again, focus on your beta-lactams here. Focus on your lincosamides, tetracyclines, and macrolides. Our fluoroquinolones, we had talked about them already, but that's why they say maybe was because we say that they're not contraindicated, but we avoided them because of all the malformations that could occur. We talked about that last semester. So beta-lactams. I'm making my note for myself, and so listen to what I'm saying now because this is the only thing that I would potentially ask. Beta-lactams, lincosamides, tetracyclines. Alright, and then our antivirals. So when you're looking at your antivirals, essentially the only thing that you have to worry about not giving them, which is something that we don't see prescribed a lot, is your baloxavir. Everything else, yes. Okay? So if you see something that ends in avir, right? Your Tamiflu, Relenza, Hermavir, Acyclovir, Valacyclovir, Famciclovir, all of these are typically safe for us to use. The only one that was not is your baloxavir. Okay? Alright. That wasn't bad. We finished. So if you can move whatever else you have. Oh, okay, so then y'all are done. I will try to make the review depending on like how I feel. I think we have what, a week? 10 days? Your exam is now on the 27th. So if you can tell me a day that y'all are like lighter, what